Okay, Michelle, I think we can start. Let Michelle introduce Theresa.
Okay, thanks. Well, welcome everyone. Thank you for joining us this evening. Everyone is on mute. Please feel to ask questions. Please type them in the chat. We will leave some time at the end to ask questions directly to Theresa, or as she's going through slides and you put them in the chat, we'll ask her at the end of each slide. I would like to introduce you to Dr. Theresa Strong. Theresa is one of the founding members of FPWR and has directed FPWR's grant program since its inception. In October 2016, she transitioned to a full-time position as Director of Research Programs at FPWR. She remains an adjunct professor in the Department of Genetics of University of Alberta at Birmingham. Theresa and her husband, Jim, have 4 children, including Daniel with PWS. Welcome, Theresa. We look forward to your research update and appreciate your time tonight.
Well, thank you. It is great to be here. I will correct one thing. As much as I would love to live in Canada, I am not at the University of Alberta, but the University of Alabama at Birmingham. So much warmer. In fact, it was 91 degrees yesterday. So we are already hitting the very warm weather. Although before that, it was really nice. It was like 72 and just gorgeous. So it is great to be here tonight. I always enjoy. I wish I could come and visit you guys in person, and hopefully, knock on wood, next year we'll be able to. But I was asked to give just a sort of a brief update on what's going on with FPWR, and I thought I'd highlight a little bit of where the funds that FPWR Canada has put into research, some of the things that have come out of that, and I really hopefully left a lot of time for discussion and questions, and really hope that we can have a lot of exchange. I'd love to hear your thoughts on the needs of your families and where you would like to see the research going, and all of that, and answer any questions you have. So with that, let me see if I can share my slides. Okay.
Uh-oh.
Team?
Oh, there she is. She's back.
Oh, yeah, she's waiting in the lobby.
Cool.
All right. I tried to keep them entertained, Theresa, but you're way more entertaining.
I'm so sorry about that. I'm not sure what happened. Do I dare try sharing my screen again? I'll give it a go, and we'll see what happens.
Let's try it.
Let's try it. If not, I'll just sing and dance.
All right.
Can you guys see my screen?
Yes.
Yep.
Okay, excellent. Well, I apologize for that, and I apologize for the delay. But I'm really excited to be here tonight and talk to you all about some of the research that is going on, and get your thoughts. So just as a refresher, our mission is to eliminate the challenges of PWS through the advancement of research and therapeutic development. I always think it's good, and I think it was Tanya who taught me this, to start with the mission and always remind people of the mission, because everything we do is really focused on that, eliminating the challenges that our kids face. And I do this for many reasons. The biggest reason, of course, is shown on the right, and that is my son, Daniel, who is now 27, and he's with Rex, his dog. And he has PWS, and he's a great kid. Actually, he's a grown-up now. He's a great grown-up. But, we've experienced a lot of the challenges of PWS, and, obviously this is something we want to make easier on all our kids and give all our kids more opportunity to be independent. So we really focus on accelerating progress towards discovery, evaluation, and approval of new therapies for PWS, and optimizing clinical care. And my vision is a world in which every individual with PWS is physically healthy, they're mentally well, and they're able to lead full and independent lives. So, we have limited resources as a patient organization, but I think there's a lot we can do with those resources. And, we ask ourselves continuously, and, again, happy to have your input on this, is, how do we bridge gaps? How do we link knowledge together? And how do we bring the right people together to advance research for our kids? So we're not going to be able to fund everything that comes in, but how can we use our funds strategically to get things started and to support collaborations that are going to make a difference? And we really have some fantastic advantages compared to, everybody else in the field. So we really understand the disorder. We know what it is to live with the disorder. And we have a bird's eye view of everything that's going on, since we get grant applications from a lot of different organizations, from both the clinical people as well as the basic scientists, and we talk to the industry people. We're able, hopefully, to bring all of those together in productive ways. And I think, bringing those people together and encouraging them to work together is one of our strongest things that we can do as an organization and as a patient community. And so using our funds really strategically, I think, is critical, and that's what we've tried to do. So this diagram shows the process that starts with research and discovery. So discovering what is different in PWS compared to typical individuals, and then using that knowledge to find drugs that might be helpful for our kids. Through the preclinical development, which is where we tested in animal models, into the clinical development, which is where we are for many of our treatments now, where mostly industry is taking that forward and testing it in people with PWS, and then hopefully into the post-approval phase where a drug is approved for use in PWS, and then we have to figure out how best to use it. And like growth hormone is an example of that. It's been approved for use both in the US and in Canada. But there's still a lot of work to be done about sort of optimizing how it's used and making sure that everybody has access to it. So along this pathway, we've tried to put into place grant programs and resources that can help push everything faster to the end point of getting drugs to all of us. So we have things like a registry that will help us understand PWS, a clinical care program that helps us make sure that treatments are being applied the best way, and other resources that are really helpful for the researchers so that they can move faster along the way. And some of those are listed here. These are things that are for the researchers. For example, we have a stem cell bank at University of Connecticut, and that's a place where any investigator can go and get cell lines that are from individuals with PWS and can be used to grow into neurons. That's those shown up here, and study to help us understand what's different in a PWS neuron compared to a typical neuron. We also have, for example, an animal model consortium, and with different models of PWS so that we can test drugs and therapies in animal models before we take them into the clinic. And we also have resources that are really geared towards the clinical scientists. So the registry, which gathers information about the serious medical events that are happening in our population and how behaviors change over time, and uses that information to understand if we do get a treatment, is it really having an important impact or not? We have a clinical trials consortium, and that is where people from different pharmaceutical companies come, and they get together with, clinicians and also with patient groups and talk about how to make the clinical trials for PWS proceed more quickly and be more patient friendly. Any of you who've been in clinical trials know that they can be quite intensive for everybody. And a clinical site database to help people help pharmaceutical companies that are wanting to do clinical trials to find the best places to do clinical trials. One of the most important resources we have is the Global PWS Registry, and I know I'm always sort of pitching this, but it's so important to our community, and we're really starting to see the outcomes from it. So this is an online database where you as a parent can go in and register your child and provide information about their medical history, about their behavior, about the medications that they're using. And we, by pooling all of that information together, we can give information back to the community about these things. It's really to better understand the full spectrum of PWS and also to help us do clinical trials. If a company is interested in doing a clinical trial, we'll send you information through the registry. We never give your information out to anybody, your personal information. But if you're eligible for a clinical trial, we'll send you that information so that you know that you can think about it and learn about it. It's also really important for helping us understand what are the areas of need. I mean, we're just submitted a paper looking at strabismus, which is like the eye crossing in PWS, and more than half of kids with PWS have strabismus. And so really understanding, is there a certain genetic subtype, for example, that's more susceptible to that? All of these questions, if we get hundreds of individuals with PWS to pool their data, we can really start answering them, and that helps all of us, be able to care for our kids better. So one thing we try to do a lot is share data back from the registry. So we have a lot of surveys in the registry about everything, again, from like behavior and anxiety, to what feeding tubes are you using, to how did COVID impact your family. And so we put out on the social media blogs every couple of months some information about that. So I hope you all see that. We also have an email list. You can just email me and I'll make sure that you're on the list if you're interested in getting these infographics about all of the different aspects of PWS that we're gathering data on. It's also on the FPWR website. And one of the recent surveys that we did was on COVID and the impact of COVID on families. And not surprisingly, caregiver stress is already quite high in PWS, and COVID didn't help any. Sleep was decreased, and caregivers felt more stressed, and they were most worried about their loved one with PWS getting COVID. Obviously, that's been a big concern over the past year. People were also worried that they would get COVID and then not be able to care for their child with PWS. And then there were a lot of concerns about the fact that, all of us were trying to do remote learning, and sometimes that worked well. Sometimes that actually reduced stress in some families, and sometimes it was kind of a disaster. Sometimes it really didn't work well. So, gaining that information was really important. We also saw that whereas medical care was usually pretty well taken care of, so people were generally able to get their prescriptions and their doctor visits by telemedicine, things like physical therapy and speech therapy were really impacted. So our kids, have pretty much gone for a year or more without those kinds of services in place. And not surprisingly, the behavior was somewhat more difficult to manage for most people. And that was, both the food-related behaviors as well as some of the stress and anxiety. So families reported that food seeking was up a little bit, not for everybody. There were some people where it was less, but generally speaking, the behaviors were more challenging to handle. We also have an ongoing study, a 4-year study that started in late 2018 called Path for PWS. And I believe about 50 participants in that study are from Canada. And I just want to give a huge shout out. Yes, I see Carol. Thank you. A huge shout out to those people. This study is so important, and it is yielding so much data. So what we ask everybody to do who's enrolled is go in every 6 months and update the information about the behavior of the person with PWS, both their food-seeking behaviors and also their general behaviors. And we ask, have you had any serious medical events? So have you had to go to the ER or hospitalization or something that was, serious enough that you had to go to the doctor and take care of it? And we're learning so much about across the ages, what is sending our kids to the hospital and to doctor's visits. So far, at least a third of our participants have reported at least one serious medical event. And the adults tend to have a lot more serious medical events than the kids, although the kids still have a significant number of events. And the most frequent serious medical events that we're seeing are related to mental health issues. Actually, that's the most common thing, either periods of aggression or some other mental health challenge. But there's also there's a lot going on with our kids, right? So this isn't, I think we all know this. There's a lot of GI issues, a lot of kids that have to go to the hospital because they, are impacted or they have serious constipation problems. We also have like the typical stuff, bone breaks and sprains. And then the more rare stuff, but equally important things like seizures. So this happens in a small percent of people, but obviously it's an important medical event when it happens. So using this information to identify those people who are most at risk for some of these health issues is one of the ways that we're planning to use this data. The other thing that we see and that we're planning on really analyzing in more depth this year is that, especially as kids get older, we see a lot of medication uses. So, growth hormone, great. But there's also a lot of medications to control behaviors. And so understanding what's most effective and, what's not, I think is going to be really important for all of us and something that we hope will come out of this study as well. Just to show you, some of the data. So one of the things that we have in the Path for PWS study is the HQCT, which is a questionnaire about food seeking and hyperphagia in our kids with PWS. And one of the questions we had was, if you have a higher hyperphagia score, are you more likely to be overweight or obese? And I think you could think about this two ways, right? So maybe if you have a high hyperphagia score, it's because you're actually in a super restricted environment, and so maybe you wouldn't be more overweight. Or maybe it's because your drive to eat is higher and that it's more difficult to control that obesity. And what we found is the latter, that those individuals with a higher score on the hyperphagia scale also tended to be more overweight and obese. And as part of this, we also look at a measure that Elizabeth Roof and Elizabeth Dykins put together called the food safe zone, just to see how restricted the environment. So do you lock up cabinets? Do you lock up the refrigerator? Do you monitor your child all the time? And what we found as well is those individuals with the high hyperphagia, the higher weight, also typically had a higher food safe zone score. So it's not that parents weren't trying and families weren't really trying to, control this. It looks like in some cases, some kids just have a much higher drive to find food, and it is just harder to control in some individuals than others. So that's an example of the kind of questions that we can ask with this data. We're also looking at mental health issues like depression. We see that about 20% of individuals have depression with PWS, and the age of onset varies and starts during childhood, but then with older individuals, it tends to be a bit more of a problem. So again, this is just the kind of information that we're finding from this really important study, and we really appreciate everybody who goes in every 6 months and updates the registry so that we can do that. So I'm going to shift now and talk about new treatments, because we have been very busy trying to develop new treatments for PWS and support the development of new treatments for PWS. So some of this has been drugs that are already out on the market, for example. So one of that is guanfacine, which is an ADHD medication, but Dr. Singh is looking at whether it can help with aggression in PWS. Some of it is CBD derivatives. So Dr. Hollander is looking at CBD-V, which is a kind of CBD, to see if it reduces hunger and anxiety in PWS. And a lot of it is still in what we call the preclinical stage, so it has not gone into humans yet, but we're, various investigators are testing lots of new things in either cells, PWS cells or PWS mice, to see if they may have a beneficial effect in PWS. So there, just so you know, there's a lot of this going on, and we're, not all of these obviously will make it to the next step and actually get tested in people with PWS, but there's lots of routes that investigators are taking and looking at whether different things might be helpful in PWS. And this is just a diagram of what has gone into clinical trials over the last several years in PWS. And I have to say, for those of you like me who have been around for a number of years, this figure is an amazing figure, because 10 years ago, it would be completely blank, right? So the fact that we have so many things that are in clinical trials and being tested to see if they have efficacy in PWS, to me, is so heartening, especially, for my son as well, but I think for everybody growing up with PWS, I feel hopeful that the landscape is going to be changing in the next, several years. So not everything has worked, right? From those of you who were around a few years ago for beloranib, that drug was actually very good at reducing hunger in PWS. And unfortunately, though, there was a safety issues with blood clotting, and it just is not safe enough to be used. So that's unfortunate, obviously, and unfortunately there were a couple of deaths associated with the use of that drug, and that's obviously really was a setback and really sad for those families. But it did also tell us that hyperphagia can be changed in PWS. So these were, adults with PWS who had lots of hyperphagia, and this drug was able to reduce that. So it does open the door to the fact that this could be treatable with the right drug. So the fact that we have all of these drugs now in clinical trials, and many of them moving forward, and just shots on goal, as they say. I know you guys are like into hockey, right? So shots on goal. We have lots of shots on goal, so that's a good thing. So I don't know if there are any questions, Carol, or I was just going to spend a couple of minutes talking about some of the outcomes from some of the where specifically FPWR Canada funds have been going.
No questions yet. So
okay.
I guess people are waiting. They're riveted.
They're riveted, or they've all gone to sleep.
No, we're riveted.
So I'll tell you just about a couple of the projects that FPWR Canada has put funds towards, and sort of the outcomes of those projects. So one is a study that Ryan Potts did. He's at the university. He was at St. Jude's. Actually, sadly for us, good for the cancer field, he has moved now into an industry position and is doing great things there. But it was a bit of a loss for our PWS field. Fortunately, it's been a very collaborative group, and others are carrying on some of the work. But there's someone with a question. He was looking at one of the genes in the PWS region, this gene called MAGEL2, and has been working for a number of years on what that gene does, or what the protein encoded by that gene does. And so he published a paper that came out towards the end of the last year. If you want to, he gives a great presentation at the Shaf Yang Family Conference that you can watch. But I'll run through sort of at a very high level, the important points. What he was really focusing on is this process in the brain and the hypothalamus where it secretes all these neuropeptides, right? So it secretes things like oxytocin and growth hormone and a bunch of other hormones that are really important in metabolism and behavior and, just how we function day to day. And in his study, what he was looking at is specifically is MAGL2, how it is involved in that process of, secreting those hormones. So what he found was that MAGL2 is part of, so those hormones are made like in a bag in the cell, and MAGL2 is really important in making sure that that cargo is delivered outside the cell. And when you lose MAGL2, as you do in PWS, the cargo just does not get delivered as well. And the group showed that in many different ways. Here's a PWS mouse, and across here they're looking at different neuropeptides like oxytocin, like vasopressin, and what they saw in all cases, it's not that it was completely missing, it was that everything was reduced. So across the board, our loved ones with PWS are not releasing enough of these hormones. And we see that because, they don't grow as well and they have, incomplete sexual development. So it's not that it's missing, there's just not quite enough there. So they showed that in the mouse model. They also showed that in family, in humans with PWS. If you look at the parents and the siblings and then the person with PWS, they have reduced amounts of many of these neuropeptides. So what does that mean? I mean, understanding that opens the door up to now looking at, okay, so what can we do to help that process be more efficient and bring it back up to where it is in the typical individual? So, they concluded that, it is the loss of this particular gene, MAGL2, that makes this process not as efficient as it should be. And that there might be now new ways. Now we can look for drugs that improve that process. So it opens the door for a new therapeutic development. It's not a new therapy yet, but what it says is if we could improve that process, we might hit a lot of symptoms of PWS all at once. So that's encouraging from a basic science standpoint. Another project that FPWR Canada funded was this project by Dr. Wells, and it was just a summer project, so it was just a little bit of money supporting a summer student who is looking at one of the mouse models of PWS. And one of the questions that we all have is, we know there is, in all individuals with PWS, there's some degree of intellectual disability, but we don't understand exactly why. What is the basis of that? And that's actually really important because there's a lot of studies going on in all kinds of different syndromes, understanding the basis of intellectual disability in that syndrome. And there are even clinical trials, for example, in Fragile X syndrome and in Down syndrome to see if, because they have that better defined, they better understand what is the basis of intellectual disability. And now they have clinical trials to see if they can improve cognitive ability in those disorders. But in PWS, we don't even know where we are yet. We don't even understand why is it that individuals with PWS, have some cognitive disabilities. And so Dr. Wells was just taking sort of a first look at some of the mouse models of PWS and looking for differences in how the neurons are in the brain. And with just one summer student and a little bit of funding, they got some really interesting results. And I think that's also on our YouTube channel because he presented that at the scientific conference last fall. Just that there are some differences. And so with that information, he's now competed for a much larger project that we're going to be funding to really go in depth and try to understand what is the difference in how the brain develops in PWS compared to a typically developing brain, and how is that impacting cognitive development. And again, by kind of categorizing that, it may help us in trying to find therapeutics to improve cognitive abilities in PWS. And the final one I'm going to talk about is a study that FPWR Canada funded from Anastasia Dimitropoulos, who's at Case Western Reserve, and she really looks at social cognition in PWS. So how individuals with PWS, interact with others socially. We know that all individuals with PWS have, they have some challenges. So it's not that our kids are not social or not that they don't want to be social, because they are social and they want to be social. However, they do have some challenges in, reading social cues, for example, in, having positive social interactions, being able to maintain those. And so Anastasia is very interested in those early processes and how that social ability develops. With an eye towards what can we do for, young toddlers all the way through school age, to really encourage that social development so that they're more successful in having good social relationships as they get older. I mean, they want friends and they want to be social, and, what tools can we give them to help them with that? And so Dr. Dimitropoulos and her group have been really productive in this area. They've been looking at pretend play, so how kids play at an early age. That's really important for how they develop, how they learn to interact and make up social situations. And they developed an intervention where they help the kids with those. What they found was, all kids with PWS have some challenges in that area. They found kids that have PWS due to uniparental disomy seem to have more challenges. And they were particularly challenged, if you gave them things to play with, kind of making a scenario up of what those objects and dolls might do. But it wasn't that they weren't interested again. And if they had someone to help them get started, then they were good at it. But they just had a hard time kind of getting started with it. So they developed an intervention to help parents with their kids learn to do that. And they did it by telemedicine again, and found that it was very helpful in helping those kids improve their social cognitive abilities. And last year at the PWS conference, Dr. Dimitropoulos, along with Elizabeth Roof and Louise Gallagher from Ireland, all talked about this social skills and cognition and the different projects that we have going in that respect. And one of our focuses for this year is, these things have been published in the medical literature, which is great because that will help other clinicians understand about that. But we really want to develop some things that are easy for parents to bring to their teachers, for example, or use at home to help our kids become more socially adept and build these skills that they need. So that was all I had as far as, because I wanted to leave a lot of time for questions and discussion, and see what your things that you want to discuss, things that you want to see more research on, get all of that. So I am happy to, stop there and hopefully have a good discussion.
Theresa, can I just say it's amazing. Like the amount of research that's been done and how this has grown is just mind-blowing and really heartening. Really? So thank you so much.
Yeah, it's been great to see. I mean, and of course it's because of all of you guys. I mean, as far as raising funds to get projects started and then being involved and doing the registry. And yeah, I know we send you surveys and, caregiver burden stuff. And the fact that all of you do it is really keeps the momentum going. I think pharmaceutical companies, when they see a patient community that is motivated, that has a need, it just is, it's really encouraging to them. When they come to us and say, they're learning about PWS, and I'm able to say, well, we have a registry, And, you know, we've done this study to show what treatment the parents want. And we've done this study to show what their tolerance of risk is. It is really helps those companies come into our space.
So if you have a question, just unmute. We're not a lot of people, and it would be better if you would lift your hand first so I can tell you go ahead. But yeah, if you have a question, just shoot.
I can jump in. And,
yeah,
oh,
go
sorry.
ahead, Jack.
Let Anna go. Anna go.
Oh, okay. Anna.
I did just speak, but thank you. So I had a question. One of the first things you talked about was the kinds of what did you call them? Like the kinds of emergency visits that you're seeing from people with PWS.
Yes.
And bone breaks and sprains was, I think, the third on the list. Does the PWS population have a higher proportion of breaks and sprains than the rest of the population?
So that's a great question that we will be asking, because it is well known that individuals with PWS are at higher risk for osteoporosis. And, you know, we don't have the numbers yet. We're a little over 2 years into this 4-year study, but that's definitely one of the questions. You know, at face value, it seems to me that it's pretty high. We see a lot of bone breaks. So I'm guessing the answer is going to be yes, but we're going to wait until we have all of that information to share that.
Okay, Jack, go ahead.
I know there's a lot of curiosity in the community around things like gene therapy. I'm wondering if you could talk about some of the progress that's been made there with the group and coalition, and the thoughts that the research community is feeling around it.
Yeah, so that's one of my favorite topics, in fact, is gene therapy. And, you know, I think it's still a number of years off for PWS, but I will say that the field is just advancing so rapidly. And that's one of the places where we've put a lot of funds lately, because I think sort of the time is ripe for that. So just as a reminder, every person with PWS, whether they have PWS by deletion or by UPD, they have the genes sitting there. All of the genes they need are sitting there. They're just silent. And so finding a way to turn them on, to activate them, has been the focus of a lot of the research. And there's several different strategies to do that. And our approach so far has been to fund several different investigators to kind of see which one works best. So we've funded Dr. Lalande at University of Connecticut, and now Stormy Chamberlain has taken over that project, and she's using these little pieces of DNA to try to do that activation. We have funded somebody else to use like a CRISPR-based molecule. So we're testing out a few things, and Dr. Younghui Zhang has found a bug that seems to activate. So we're testing out a few things, and I think it'll take seeing which ones work best in the mice to see which ones we want to move forward. But certainly there's a lot of reason to think that, not in the near term, but in the long term, you know, it might be possible to do this. Now, there's lots of questions that we're still asking. For example, my son's 27. Can you turn those genes on in a 27-year-old, and would it matter? Or would you have to do a brand new baby? And we're also funding studies to ask those questions. So Dr. Resnick at University of Florida, he has a mouse that has the genes off, and then he can flip them on at any time. And so he's flipping them on in baby mice and teenage mice and adult mice, and then he's going to see if it makes a difference. And I mean, that would be important to know. I mean, it may be that older kids are not going to receive that much benefit, and then you don't want to go giving them gene therapy. Or in some cases, because this has been done in other disorders as well, you can, make a big impact in an adult by, replacing a gene or turning a gene on. So those are all things that we have to sort out and figure out. But there's a lot of reason. Again, the technology has advanced tremendously in the last 5 to 7 years. So we really want to be sort of on top of that and riding the wave, so to speak.
So one of the questions I have is, I have two questions. Number one is, what excites you as a mom? What research is exciting you the most? And number two, how do we get, once we do get a drug approved, and I know I'm talking hypothetically and in the future, how do we get that stuff also to Canada? Because you guys are in the US and I know everything gets FDA approved. How do we get that to Canada as well? Those are my two questions.
Yeah, so the first question, what excites me? The gene therapy, I think, is exciting. It's just an interest of mine anyway, and I think it's very attractive to me to think that, maybe in one fell swoop you could kind of fix everything.
Right.
Wouldn't that be nice?
Yeah.
It also is the highest risk, right? A lot of things could go wrong, and it'll take a long time to, sort through whether it's feasible for our population.
Okay.
I also really like the work that Ryan Potts has done with the secretory granules, because to me, that's a little bit more like you could see a drug, or you could screen for a drug that improves and we don't have to go from 0 to 100. We're at about 50. We just have to get it a little bit better. And you could see where getting it a little bit better could make a big difference. If our kids are internally getting more oxytocin, more vasopressin, more of all of those neuropeptides that they need, like a little bit of a change might make a big difference. So that's really attractive to me. And that's something that I think that we really would be important to push on. And then, of course, the drugs that are in clinical trials, being able to bring them to our kids and test them and see what works and doesn't work. And, that's all very exciting to me. And then with respect to bringing drugs to Canada, I mean, we'd have to partner with you guys on that. So, from the growth hormone thing that it's a challenge, but, yeah. But if it's clear that a drug is having a positive effect, then I think, you're in a much stronger position to make that argument. So, while I know it's ideal to have the first thing be that it be approved immediately in both countries, we can hopefully use the information gained in the US to support, Canada. And Tanya, yes.
I can add to that.
Yes.
So that's what's amazing about having a close partnership is, like, we're essentially the same organization, right? Canada basically raises money to send to our sister partner, and then our sister partner supports us if we have challenges accessing. And so what we've done is also put together a committee led by Celine LePage, who has been attending every single CORD conference and working with people in our Canadian government to try to figure out how to partner with all the drug companies and get access to all of these drugs once they come. And so that's what's actually helped us get growth hormone in Ontario. And then we're trying to spread that across the country. And then secondly, I just lost my train of thought. There was Celine. I'll remember. Sorry, guys. I had a really good point. I'll come back to it.
Well, I think it's encouraging too that, I know Levo has done their trial in Canada. I mean, several companies have done trials in Canada. I mean, Inversago is another, I think it's a really interesting drug, and they're Canadian based. So I'm sure I don't know if their next trial is going to be in Canada or both, but there are some Canadian-based companies as well that are developing drugs for PWS. So yeah,
that's actually what I was going to say. We encouraged Levo to come and do the study at Sick Kids, and I think we also tried to get it into Alberta. So the more we can do that, which is why our partnership is so important, the better chance we'll have as Canadians to get those drugs approved if they're being done in Canada. So, I mean, either way, if the drug is working, we should get access to it. And I think the world right now is learning that this, like the vaccine, how much it's helping the whole world, and how you got to start making things quicker and get access to those drugs that are helping.
You know, that's a great point, Tanya. That the scientific community has learned a lot from the COVID experience as far as getting trials done remotely, you know, I mean, without having to do so many clinic visits. I mean, I know like Canada's a really big country. You guys probably have to mostly travel really far to clinical sites. And if people can do more things in their home, you may be able to bring more people into the clinical trial process. So hopefully there's been a lot of good lessons learned, and I think there's a lot of people who want to make sure that we don't forget those lessons and we continue to apply them not only to COVID but to all of the, you know, the clinical trials that are going on.
So we have a question from Gloria and Joanne. I don't know who that is. Just unmute yourself.
Hi, it's Gloria from Winnipeg, Manitoba.
Hi.
Hey.
Hi, and there's no Joanne. She was part of another topic that I guess we got the same link from another time when we joined a conversation.
Okay.
But anyway, you mentioned that that like with the growth hormone that Canada can have growth hormone now. So I'm just wondering, has that changed for us? Because 10 years ago, like my daughter is 26 right now. And so initially, when she was 4 years old, I had to fight for it, and Jennifer Miller helped me to get it for her when she was, because her doctor was refusing it. But then he agreed to get himself educated through Jennifer, and then he agreed to test her, and she was growth hormone deficient, so was put on for that reason. When she was 16, the endocrinologist here refused to continue the growth hormone. So then I finally found a different endocrinologist that agreed to to work with me. And then again, worked with Jennifer Miller again. And then she agreed to have her tested because she had all the characteristics of not having deficiency. But then anyway, so Jennifer worked with my daughter's doctor, and then they learned that even though she didn't have all the characteristics, there was something else that showed that she needed growth hormone. So the doctor allowed her to get it, but that was still under the umbrella of being, in order for it to be covered under pharmacare here, it was still under the umbrella of that she was showing deficiency. So has something changed now that in Manitoba that she can now get it even if she didn't show deficiency?
We've kind of solved the problem in Ontario. We're trying a one province approach because our goal is if we can get it approved and dealt with in Ontario or one or two provinces, then we have a leg to stand on with all the other provinces. So we literally just got this done in the last 6 months. So now we're going to try to go to every single province and get it completed so that every province has access. So yeah, they're Health Canada, they're tough, but we're tougher. So Jack, do you have anything to add to that?
Yeah, I was going to say it was added to the Ontario formulary, which is a huge step. Especially, there's a lot of conversations going on right now about orphan drug access across Canada with Health Canada. So Celine's been involved in some of those conversations and meetings that have happened, and just the government's just trying to figure out how to fund and how to provide access and enable the provincial formularies and pharmacare systems to be able to deal with orphan drugs because it's such a problem in Canada. So it's slow going, but there's a lot of change in the works, I'll say. And for specifically growth hormone, the fact that we were able to do that for Ontario is huge. It'll hopefully have a domino effect over the next few years.
And we are raising money for research, and part of research is figuring out a way to get access to the drugs when they do become available. So we've invested a little bit of money, time, resources into the drug access part of it. So we're trying to basically build and deal with the whole portfolio. Yeah, so I see more questions, so I'll stop.
So, yeah, Anna, you have a question?
I was just going to add on to that. Thanks. In New Brunswick, we had been in touch with Celine, and the doctor that made this submission in Ontario, has shared the materials with our endo here in New Brunswick. And so, that could be another parallel course to take within the different provinces as well. So our endo is going to make a submission on, for the province of New Brunswick.
I have a second part of the growth hormone. Her endocrinologist right now recently has been suggesting to take her off growth hormone because of her diabetes. So she's saying that there's that the growth hormone could be making her diabetes more problematic. Is there any truth to that?
Well, I'm not a doctor, right? I'm a PhD. I can sequence your DNA, so you got to take what I say with a grain of salt. But
okay.
I mean, growth hormone can increase blood sugar. I think a lot of endocrinologists, because honestly, I just had this conversation with my own endocrinologist because Daniel's having some high blood sugars as well, and his feeling was that. You're just replacing, you're not like, yes, if you overdid the growth hormone, it could be detrimental, but you're just, if you're bringing it up to the normal levels, then you might want to look at other ways to try to bring the blood sugar down. So,
okay.
Again, I'm not an endocrinologist, but you might want to talk to someone who is really familiar with PWS and see if there are other options.
It's like the doctor who says the sleep study came back with some sleep issues, so stop the growth hormone. It's like, well, no, treat the sleep issues and continue the growth hormone. So you need someone well versed in it. And one person we found here in Canada that's our Jen Miller is Jill Hamilton. So we're trying to find more and expand it, and there are a few across the country, and so we're just trying to bring them all together. One thing I did want to share is when 15 years ago, when I first met Theresa, we brought Dante down to Kentucky, which is, you do your Google search, what do I do now? I just got this diagnosis, and we ended up meeting Theresa and her team when FPWR just started. And I remember asking Theresa, okay, what's it going to take? How much money do we need? And what can I do? Because I know nothing about science. And so after listening to Theresa and, listening to the need for research and all the things that have to be created and built before this stuff is actually able to happen, which is everything she shared today, is we need that base funding to start these projects. And so I took it as my role to go back, who doesn't know science, doctors, medicine, and said, well, my role as a parent who's passionate, who wants answers for her son, is maybe to raise a little bit of money. And so that's kind of how FPWR Canada was born, and One Small Step was born, was this, meeting with Theresa and her team and this group of kind of passionate parents who just want to find answers. And it's grown significantly over the years. And I'm just so thankful for everybody that's on this call today. And, when something does come up, like a One Small Step virtual event, or, something you're passionate about, or perhaps maybe you do have a science background and you want to help, Theresa in some way, that we can find a role for you and put you to work. And the more people we have working on this and together on this, I think the faster we get the answers. And so thanks to everybody who's been here. And Theresa, as always, I learn something new every time you present, and I really appreciate everything you've done over the last 15 years for my son. So I just want to say thank you.
Well, thank you. I'll just reiterate that one of the amazing things that I've learned along this journey is that, I know science, right? I'm really lousy at fundraising, but I know science. So I'll do the science, and, Tanya's fantastic at fundraising, and somebody else is fantastic at raising awareness. And, you know, it really does take all of that fitting together. And it's just amazing how much we can move when everybody, you know, works to their strengths and, you know, sometimes a little bit outside your comfort zone, but, you know, just, you know, making a contribution that you can make. So whether it's like filling out the registry or, you know, or holding a walk, you know, whatever it is, there are so many ways that you can contribute.
Absolutely. And just letting everybody know, PWS Awareness Month starts Saturday.
Mm-hmm.
And we have all kinds of things. Watch for your emails. We are sending an email out tomorrow with some a great game that you guys can participate in and all kinds of stuff you can do for PWS Awareness Month. And so that's going to be fun. Anybody else have questions before?
One more thing. If anyone does have a question, because I know that was a lot of information, and you think of it in 20 minutes or tomorrow or whatever, you could send Carol an email and we could fire off those questions to Theresa at a later date.
Absolutely.
And she's happy to answer those. So please don't be shy. And if we can keep the meeting going for another few minutes if you do want to unmute yourself and ask any questions.
I wanted to also say we are recording this this meeting, so if you're going to get it through email. So if you want to rewatch it and reanalyze it on your own, and again ask us questions, send me the questions. I'll be happy to forward them to Theresa. So anybody else have any questions? Juliana's wearing her costume.
Everyone's just COVID tired.
COVID tired. All right. Well, I guess we'll end it here. It's 8:08. So thank you everybody for participating, and we will send you the recording. And again, if you have questions later on, email me. It'll be my pleasure.
Thank you very much for getting us together, and thanks, Theresa.
Thanks everybody.
Bye, everyone.
Thanks, Theresa. Thanks, folks.